Well, what would you say about social determinants of health? Because it would, as you look at interventions that are needed in Southern Africa, and I visited Khayelitsha and I visited Guguletu, and the living conditions are very poor.
Well, I mean, I think
Is a TB intervention actually creating more, better housing conditions, or actually creating windows, or is it?
I think you're absolutely spot on. Again, I think that one becomes, initially you start off by being quite focused and saying, well, can you reduce the burden of TB and HIV? But of course, tuberculosis is a disease of poverty, and it's not just tuberculosis and HIV in these communities, it's environmental exposures to worms, to hormones, to tobacco smoking. 80% of children in our current community studies have a parent, if they're a TB index case, who smoke. So the adult who's the source case actually smokes. Children are also exposed to tobacco smoking, which increases their risk of all kinds of ill health, including pneumonia and other respiratory tract infections and tuberculosis. So I think that interventions which are just, again, I think tuberculosis is a gateway. If one has well-established platforms and you have entry into communities and households, then I think there's scope to be doing larger interventions down the line that will change or improve people's living conditions, and where one would not only look at tuberculosis as an outcome, but look at other important measures like child lung health, for example. But those require huge structural and large political interventions and huge amounts of funding. There are things that one can do in the shorter term which may be very effective, and that would be issues like increasing food security in the household by getting parents to smoke less, buy more food for their children, drink less alcohol. I mean, communities where you work have very high rates of fetal alcohol syndrome. So resource allocation and shifting money around within a household could also be an effective strategy. And the poorest people are smoking the most and drinking the most in our communities, and we've clearly shown a risk of all kinds of ill health in these communities related to tobacco smoking. So even if we cannot physically change everyone's immediate housing structural environment, we can educate people about ventilation, about air, but certainly about tobacco cessation, about general hygiene, cough etiquette, etc. So again, I think tuberculosis is a gateway. If we collect data on epidemiological and social determinants, it highlights other burdens of disease that maybe have not been so sexy, and that people have been ignoring for a long time. The issue of poor nutrition, and so in these communities where TB and HIV are very common, tuberculosis is still a rare disease. The main concern every day is probably, what are you going to eat? So we are tackling diseases of poverty, and I think we need to come up with interventions that are really going to benefit the communities where we're working. And I'm speaking from a research perspective. And there's a social responsibility to improve the amount of knowledge and access to care and access to other interventions in the communities where we're doing our work. I feel very strongly about that.
Can I just ask you one really basic question, which is, of the adults who are developing active TB, how many of them are actually contracting the disease initially when they were children?
It's actually quite an interesting concept. I think in the US and in Northern Europe and Southeast Asia, the notion is that if you're an adult, you actually have reactivation type disease. So you've contracted the infection a long time ago.
Right.
I'm talking about HIV negative adults, and then many years down the line you'll get tuberculosis. In high burden settings, most of the cases of tuberculosis in adults are really attributable to recent exposure in the last year or two. And there's ongoing exposure. So there's a reactivation tuberculosis, yes, as well, but there's a lot of primary progression because of recent exposure. So one very easy way to quantify that is that within households where there's an adult with TB, you find many more other adults with TB just because of that recent exposure. So if you do active case finding of, if you're an adult and you go to a TB clinic and I go to your house, if you're the adult index case, I'm much more likely to find other adults in your household, and of course children in your household with TB. And between 5 and 10% of people that you would screen in that household would end up having TB, depending on what age about 5% for adults. So there's a very high risk of developing disease in the first 2 years following exposure and infection. HIV positive adults really are a bit more like children when it comes to their immune system, and their risk remains high and it's constant. So recent exposure is still a very high risk factor. In high burden settings, we do have reactivation disease, but recent exposure is a very high risk factor for them. And that's again why active contact tracing is a very useful strategy. To not only find more cases, but to make people aware of tuberculosis. Because when someone is ill and they're coughing in the household, other people get concerned about their health. So much more so than when we go into households where there's no one coughing and we want to ask them the same questions. So people are concerned when other people around them are coughing and are ill, and maybe that's an opportunity for health education and intervention.